Now I really would like to share our experience with the use of LineRT in our center. I work in Italy, in a city. The name of the city is Novara. Is located in Piedmont, is in the northwest part of Italy, between Turin and Milan. And actually we have to manage a relatively large geographic area, and we receive a patient from relatively large part of country. We have a country of about almost 1 million inhabitants. This is a small picture of the city. This is a quite old hospital, historical building, but we are planning to have a new hospital hopefully in a few years. This is the department. We have 4 Linux, and all of them are equipped with LineRT. One is equipped also with the ultrasound system Clarity, and one of them is actually located in a satellite center 20 kilometers apart. We have also Linux for intraoperative radiotherapy, of course, all the devices for simulation, brachytherapy, and treatment planning system. We are 10 radiation oncologists. We have also in our, it is a relatively small academic center. We have also residents for radiation oncologists. We have physicists, technologists, 17 technologists working on the Linux, and working also for the simulation. Nurses, administration. This is roughly the number of patients we treat per year. Most of them are breast cancer, and a quite large percentage is actually prostate. In terms of IGRT, we really decided to move to LineRT in 2006 when we installed a Linux, and we asked to have, there was no possibility to have a real Conbino.Linux, and we decided to have a surface alignment system. And we were quite happy about that, and we decided also to implement the same system on the other Linux in just a few years. And now we have all Linux equipped with LineRT. We know that we have a number of IGRT methods. We can use, of course, methods to identify the target and the body surface, like Conbeam. We have other methods just to identify the target with possibly radio frequency, or by using also ultrasound, or just monitoring the movement of the organ by implantation of fiducial marks. And then we have the body surface systems. There are also other methods using infrared, but not acquiring the full surface of the body, but just points. For example, in Italy we have a center for particle therapy, which is equipped with this kind of device. Of course, whenever possible, we prefer not to use ionizing radiation, but to use technology which can allow using really less invasive methods, and limit the use of ionizing radiation when is really needed. LineRT technology really is a very fast method, and also our technologists are very pleased to work with this so fast system, allowing to take, we heard, about 20,000 points, and reconstructing really the body surface. We can also check the patient position not only at the moment when we do the setup of the patient, but also during treatment and even after treatment, just to check if there was any change of the patient setup. Well, we started to analyze the issue of pelvic tumors, and we started with prostate cancer. At that time, we didn't have yet the cone beam, and we decided to correlate with bony anatomy by using the EPID. We analyzed 16 patients. And we actually observed a relatively low systematic and random errors. But most interesting was that there was a correlation between the errors measured by aligner T and measured by EPID. And the difference was really very small. These setup errors were very reproducible and correlate quite strongly with the setup errors detected by EPID. So also based on that, we decided to continue obtaining daily images by aligner T and limit the use of the EPID. Just once a week and no more. But we are really quite confident about the daily use of aligner T that correlated also with this bony anatomy. Then we decided to study if there was any correlation between the errors detected by aligner T and the errors detected by the Clarity, the ultrasound methods. We investigated and analyzed 40 patients, and we decided to analyze the patient just before the start of the treatment. All patients were treated by IMRT with conventional fractionation until the total dose of 76 or 78 K. And this was the difference detected by the two systems. And it is interesting that the distribution was not really a Gaussian distribution, but there was some asymmetry in this distribution, showing that probably there was not only a random error, but also some difference in detecting the systematic error. And analyzing more in depth the systematic and the random errors, we found that probably in the lateral direction there was some difference in detecting the errors between the ultrasound and the aligner T. We thought that probably this could be related that the lateral aspect of the prostate is quite difficult to analyze and to detect precisely by using the ultrasound. And actually we observed that if we can correct the systematic error typically in the first 5 sessions, then we can quite safely use the aligner T because there was a very strong correlation in terms of detecting the random error. In this sense, the ultrasound could be the method to detect the organ motion and to really monitor in the first session the organ motion to identify the systematic error, and then the patient could be followed by the surface matching images by a line RT just to monitor the random error and correct in case the random error. We validated this aspect by using the EPID system, but now we are analyzing this data also comparing CBCT. We have not matured enough data about the use of CBCT, but we hope to have quite soon this data. Another issue that we tried to investigate and we found quite interesting was the intrafraction motion. Intrafraction motion, again, in pelvic tumors. And we decided to obtain images by a line RT, not only at the start of the treatment, but also in the mid of the treatment and at the end of the treatment. And we obtained a quite large number of images, more than 6,000 images in 29 patients in almost 800 fractions. And actually what we found was quite interesting. There was no really difference in the possible displacement during treatment between the first sessions and the last session, but there was some change during each session, and this change was mainly in the first part, in the first minute after the setup. We tried to envisage the possible reason of this, and this possibly could be related to the contraction in the very first minutes and then the relaxation of the pelvic muscles. And actually this change was mainly in the vertical direction and was much less in the lateral and longitudinal direction. But this change was very similar in the first session and in the last sessions. This could mean that if we deliver in a very short time the treatment, maybe we could have in the first 1 or 2 minutes we could have some change of the position of the patient, and this was detected also by other authors by using also different systems like for example electromagnetic transponders. Another issue we tried to analyze was breast cancer, and we analyzed 15 patients, and again we matched the surface imaging with radiological images detected by the EPID, and we found a strong correlation. This was not really unexpected because the breast is a subcutaneous target and very close to the thoracic wall, and as we expected there was a correlation between the position of the bony anatomy in terms of thoracic wall and the surface of the patient. And actually we typically monitor the patient during treatment at each session with a line RT. We still, about the tattoos, we still are using the tattoos, but we reduce the number of tattoos. So we just make two tattoos for the initial alignment. But in the future, we are thinking about the possibility to skip completely the tattoos. And I'm really very interested to learn from you and listen from the community if this can really be the way where to go. And another tumor site we analyzed was brain metastasis. We typically treat with stereotactic radiotherapy, and we analyzed with aligner T 62 consecutive patients. We usually use aligner T as a first modality to check the setup of the patient. There was also an interesting issue about that, because we performed also a kind of proactive analysis to identify the possible risk in stereotactic radiotherapy for the brain. And one of the most risky steps we identified was really the position of the isocenter. So in this case, the use of aligner T can really make much stronger the procedure and much safer, I have to say. I think we published this data on a paper on PRO journal, and I think that was quite interesting because, of course, we applied the FMEA analysis, and by using FMEA, of course, you can detect problems in a procedure, in a process, but by using stereotactic radiotherapy is in many cases just really a single shot procedure. So it's really a crucial point, the risk analysis. So one reason was to make safer, and the other one we really tried to analyze the changes of the position of the patient with respect to the cone beam CT. And these are the results. And we had some spread of data more in the vertical direction, possibly related to the system that can really move a little bit during the setup of the patient. Is quite stable, but in less than a millimeter you can have some small changes. Less changes in the longitudinal direction, which was really reliable, and again also in the lateral direction. Then, last but not least, really lung cancer, but we are just approaching the issue. We use for the patient setup, in case we correct the position, if aligner T detects some errors, as you can see in the upper part of the picture. And then we use aligner T to monitor the movement of the patient, just to be safe that the patient maintain the range that we decided to use for the treatment. But we are still implementing. We have not yet clinical and reliable data to present. Trying to make some conclusion or just give some final message, we think that in our experience the routine daily use is really fast and safe for the verification of the patient setup. And we identified for pelvic tumors a strong correlation with the EPID and the US systems, and we are investigating and analyzing the correlation with the CBCT. We verified also the intrafraction setup movements, and we think that also this use that can be performed by just acquiring some images or monitoring the patient over treatment. This use is very promising and interesting. And it makes also safe the procedure for the stereotactic radiotherapy of intracranial lesion. And we know, of course, that for the respiratory motion is really a great tool, but they are still investigating and analyzing this issue. Thank you very much for your attention.
I have a question related to your prostate treatment. I think by principle it cannot be possible to find a correlation between SGRT and the target you want to treat, because prostate moves on a daily basis, as we all know, and you cannot pick up that with SGRT. So either you position on growth markers implanted, or you are using CBCT and match on the organ. And then, of course, the surface of the patient will always be at a different location in space on a daily basis. So SGRT is good for initial positioning, but then you need another means to really position your target at the isocenter and not your organ.
Yes, of course, we are actually analyzing the data if there is any correlation also with the CBCT, but we know that the fullness of the bladder and the rectum can make some change. But it is interesting that there was anyway some level of correlation. Then probably there is still, at least in some direction, not in probably the whole direction. In the vertical direction, AP, probably there is more uncertainty between the SGRT and the target position, of course. But in the longitudinal and in the lateral direction is relatively reliable.
I have a question about your brain stereo. Can you go back? Is there a typo, or is really the results? Because you present results of disagreement of 4-5 millimeter. This is huge. Or was it written wrong? 0.4 millimeter.
It was 0. Millimeter.
0.4.
Yeah. Sorry.
Because
Sorry.
that was written
Yeah. No. Is a point. Yeah. Of course. No. Yeah.